Hi everyone. Welcome back to yet another interesting episode of FCPI podcast. So, this is our eighth episode, and as you know, for through FCPI podcast, we are trying to explore different arenas of clinical pharmacy at a global level. So, you have been listening to us discuss about various aspects of clinical pharmacy, including soft skill development. And today, I'm really excited to do this podcast with yet another professional from Africa. And today we'll be discussing about improving engagement with early career professionals in antimicrobial stewardship. So I would like to welcome the guest for today's episode, Daniel Warungi. Thank you so much, Daniel, for accepting our invitation and for joining today's podcast.
Yeah, thank you so much, Vrinda. It's good to be here and it's good to have this conversation. It's something that I'm passionate about. Yeah, and I'm
Great.
happy doing it as a pharmacist. Thank you.
Great. Before we begin, I just want to introduce Daniel to all the participants who have joined us. So, Daniel is a social entrepreneur, pharmacist, and a passionate public health professional. He's the co-founder of Sihi Institute, a non-profit and research organization that applies community-centered designs to implement health resilience interventions in underserved regions in Kenya. Prior to that, he has also worked in React Africa, leading antimicrobial stewardship program in Kenya and youth engagement programs in Africa. In addition to that, he has also co-founded and led to other organizations before, which are Students Against Superbugs Africa and Rye Culture Health and Social Innovation. He has served in multiple advisory positions and supported the Kenya government as well as multiple other organizations on AMR and infectious diseases. So, from a professional background perspective, Daniel has pursued pharmacy at Kenyatta University of Agriculture and Technology in Kenya. And he also has two postgraduate certifications on project management and policy development and advocacy from University of Washington. Wow, that's an amazing profile to read. And so great to have you
Thank
on this
you. Thank
podcast.
you. Thank you. I appreciate.
Right.
Thank you so much.
So diving in right away, so the career that you have chosen, so from the profile itself, it's quite clear that you are very much interested to work with the community and with the youngsters on antimicrobial stewardship and other initiatives around antimicrobial resistance. So I
Yeah,
was actually wondering what sort of motivated you to choose this career path. So this is not a traditional pharmacy career path that you have chosen, unlike
yeah,
many of us who have gone through the traditional pathway.
yeah.
This is quite different. So I was quite intrigued to just get to know you from that perspective. Like, what actually motivated you to go into this field?
Yeah, thank you so much, Vrinda, and thank you so much for the wonderful introduction. I'm happy to be here to share my story and what inspires me. So I would say, really, my journey didn't start like as a plan, like had strategized to engage in this, but it just happened as a simple encounter, and it was back in the days, I think around 2018, where I had the first case of a child who had drug-resistant infection. And back then, the guidelines that we use are quite expensive, and they were from an urban informal settlement. And the parents really couldn't afford the medication, so they were trying to circulate around different facilities. You see, was trying to see whether there are cheaper alternatives to it. And I think that case of facing antimicrobial resistance face to face, I think that's what first drove me into this
Right.
field of antimicrobial resistance.
Hmm.
But then the aspect of engaging now early career professionals and tertiary students then came after my understanding. As a pharmacist, there's that understanding that you have of AMR. But I think as you work more in this sector, you also get to understand there are deeper issues to it. And, from my understanding, right early then, I saw AMR more as a behavioral challenge
Hmm.
rather than, and one of the best ways to actually shape behavior is to also start at a younger level, and
Right.
people who have not been pre-exposed to existing norms a lot, those are the
Hmm.
people who can, kind of adjust their practices easily. And
Right.
I think from this, then we had this dream of building a multidisciplinary pool, not just healthcare professionals, because, AMR is quite one health issue. So we thought that if we're able to invest a lot in tertiary level students and early career professionals, probably within the next 10 years, we'll have people who understand the issue better, are quite, passionate about the issue. And these people will not just be in facilities in hospitals, but they also be, people, careers take them, in very different spaces and
Yes.
areas even they never anticipated. So maybe during that time, we might have maybe one of the people that you worked with being a minister somewhere, being in a policy somewhere, or leading an international organization somewhere. And that would really help a lot when we have people in such influential positions, catalyze a lot of MR engagements within Africa. So that was the motivation. Thank you.
Amazing. That's so interesting and inspiring to hear your story and where it all started from. You mentioned about that you are currently working with tertiary care students as well as early career professionals. So, what are some of the activities that you engage with them? Are they all like educational activities, or yeah, just could you elaborate on some of the activities that you do with these cohorts?
Yeah, so our work is has kind of improved iteratively over the years.
Hmm.
It's more of pilot, have findings improve further. So the current model that we use is more of holistic capacity building,
Mm-hmm.
but rather it's tied also with experiential learning. What I mean is that we have most of our programs actually, we have that holistic, not just training them on AMR, but we also cover other areas such as policy,
Okay.
project management, so that community engagement, a bit of lessons also on communication,
Mm-hmm.
behavior change, so
Nice.
that they have access to this information that can actually help them now maybe engage in an intervention or where they go, at least they are well capacitated, because you can have the knowledge on AMR and you are pro in this, but you don't know how to package it well, to different audience.
Mm, mm,
Maybe you don't know how to run a project in best practice, report well or get funding for an activity that you want to do. So our training kind of focuses on all that. But then training is not enough, because one of the things that we realize is that the moment you do a lot of training and there's no that experiential learning, then apart from it remaining in theory, it doesn't expose people to the challenges that exist in their different settings. And in our case right now, let's now take the focus maybe of facilities. If you engage, let's say, pharmacy students or early career pharmacists who are beginning their practice right now, and you teach them all this, but you don't kind of also expose them to somewhere where they can actually like interact with patients, especially for pharmacy students, or where they can actually do something where they have now to tackle a problem head on, then it becomes so difficult for them to actually understand the issue. Like myself, I
mm.
only came to understand this after I had had that practical encounter.
Right.
And so, what we do after this capacity building, we also now offer them seed funding to run a project. And it's not that we
Amazing.
prescribe projects to them. What we do is that we have that session whereby they conduct a bit of reconnaissance. If you're working in a facility, or if maybe you're doing a bit of rotations in a facility, then you kind of go around and see what are the gaps here. You engage the key stakeholders within that facility. And then after that, what you do, you draft a proposal, share with us the proposal, we help you refine it. After that, we give you the funds, you implement the project. Mostly they're usually pilots, not very big projects, maybe a 2 month project, 3 month, 5 month project. And then after that, you share with us the findings. But now after the findings, we have a session whereby we call them cross-learning pods. Now, these cross-learning pods is where people now kind of anchored with that experience that they have witnessed on the ground or where they were actually engaging. They then can engage in discussions. Okay, so this is what I saw in my area. These are the challenges I faced when I was implementing my interventions. Then someone else shares, and then there's that cross-learning aspect. And one of the unintended benefits that we saw from this is that it actually I think it made people more passionate than we had. That we had, so that was we didn't like we saw maybe before during the training and all that people are not so much immersed into this issue, but after they have had that a bit of experiential learning, then you can see they really want to do more into this area. And the reason we don't prescribe projects, or like we tell them, okay, we want you to go to maybe do a certain a certain project, is because we feel when it comes from them kind of understanding the gap in their setting and working around with stakeholders in that setting, then they then come up with a project that they think they can do best. And it also has a factor of sustainability to it because
Right.
of that ownership. Yeah. So let me just pause for there for now. Yeah.
Right. So, just to understand this correctly, so you do a little bit of theoretical training in the beginning, and then you give them an opportunity to sort of implement what they have learned in their own setting, like a short project in that aspect. Is that correct?
Yes, 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 yes.
Okay. So since most of our audience are also pharmacy students, I think it would be also beneficial for them if you could just elaborate on the kind of trainings that you do, and also what are some of the major research projects that your students take up. So it might be good for our audience also to get some ideas on what are some stewardship initiatives or stewardship activities that they can also start in their hospitals.
Yeah, so let me try to contextualize it now to the
Yes,
pharmacist.
absolutely.
So, for our training, since our our training is usually multidisciplinary, so
Mm-hmm.
we don't very much focus on, we start from the nitty-gritties, because in that training, what we do is, when we call for cohorts, we have people apply in teams. For
Mm-hmm.
example, if we have people from a certain university, then apply, as a team. And the team needs to have different people from different cadres. And the reason is we also try to, if we have different expertise then coming together, then it means even the richness of the interventions that we'll actually, ideate or come up with will also be quite rich on the same. But now in the context of this, we start training from the very basic, because we have people who don't, understand before about AMR. They've never heard
Right.
about it. Maybe we have pharmacy students who have maybe learned about this, or two maybe in a microbiology
Hmm.
class or in a pharmacology class. But we start from the basics just to appreciate those who are not. And then we come and take them up, and we have these group settings whereby, for example, pharmacy students, apart from them learning, they're also able to teach others, within their setting. So there's that also kind of peer learning that actually
Right.
also happens. Then after we have this learning, we start with the technicals, right from the basics in infectious diseases, the basics in microbiology, what is a bacteria, what is a virus, what are the mechanisms that resistance develops. We are skilled that way. How do we understand AMR from an health lens? How do we look at it from a human health aspect,
Mhm.
animal health aspect, environmental health? What are the linkages, in between? And then understanding all this, then we now go to, the policy aspect, and we kind of try to have that systematic approach, so that right from the basic, and then we go on. And one of the things that we've realized about having this is that for the pharmacy students, they might be so much educated in regards to the pharmacology aspect, the mechanisms of resistance, the antibiotics that we use, the type of antibiotics that we have, first line, second line, third line, our classification, all as per their country's antibiotic guidelines and all that. So they have the expertise on this, and also the microbiology. For microbiology, they might have maybe deeper expertise on the same. But then you find we have a gap when it comes to policy. And the
Mm.
reason is, we technical people sometimes, we are very good at, we know what needs to be done. But then to package it to someone who is not as an expertise as us, and realizing that not everyone understands things the way we do
Right.
understand. For example, where do you use storytelling? Where do you use statistics and all this? Then so that's the aspect of the training now. And then now let's now come to the project. Now for this team, for example, they decide, okay, we'll do a point prevalence survey in a certain facility. And now you have a pharmacy student there, but you also have someone who is maybe doing another course, maybe a medical course, a microbiology course, and maybe you have also someone from tech. And then now we'll tell them, okay, so this is how we point prevalence surveys have been done before. I've worked a bit in antimicrobial stewardship also. On that, I may also do a bit of work just to, not to retain my pharmacy acumen. But then we challenge them, okay, we do point prevalence surveys this way. But you see, how can we make it better? Think of something or, within your expertise. Will you try to house the tool somewhere that is actually more accessible? As you are collecting this data, is actually more accessible. And also, as you collect this data, are you able to detect some challenge? For example, the filing system that exists in this facility, is it automated, or do you have to, for most public health facilities in Kenya, you still have the hard copy files. And so how can we, would you doing this project, we kind of help them kind of think in a way that, okay, you're doing this, but you're also maybe identifying a gap, so that it's more of a pilot, so that even after we finish the program, you kind of think, okay, I noted this, maybe I can try to apply for a grant somewhere and try to automate some of these things, or kind of try to improve a bit. Yeah. So that's how we kind of do this. There's also the issue of hospital management systems and all that. But our interventions are not just based in the facility setting. What you realize also is you have pharmacy students who may not end up even selecting maybe a project that exists within their conventional scope of practice. So you find someone, they kind of discover an interest even as they are engaging in this. And this kind of, we've seen kind of career trajectories. We have someone maybe engaged in a course, and then after that, for example, let me give this case, and it's not of a pharmacy student, but it's a veterinary student who,
Yeah, yeah.
when they began, they were very mainstream on finishing, then going into the conventional veterinary practice.
Hmm.
But then after engaging in this, they kind of had a bit of interest in microbiology.
Mm-hmm.
So it kind of shifted their career a bit. And they did a master's in microbiology, but it also shifted the trajectory of their career too. Yes, they're doing microbiology, but it's more targeted towards coming up with AMR interventions and seeking for jobs within that field.
Right,
Yeah.
right, right. So how long do you do this training for? Like, is it like a 2 months training period? How long does the training last for?
Yeah, so the training varies with different programs,
Okay.
also depending on the funding that we get to go, because they're also very the financials that we have, because they're also very resource intensive projects.
Yes, yes.
You also have to give mini grants in the same. But for the best projects that we've seen, like the ones that we've seen actually work very well, the ones that were most successful is where the training actually went for 5 to 6 months in
Okay.
terms of now the basic training before. And then after that, before we go now to the aspect of the actual implementation of a pilot project, we had a simulation process whereby they ideate interventions, just a simulated
Yes,
intervention,
yes.
just to guide them through the
Mm.
nitty-gritties in terms of project implementation, and also to help them realize what are some of the key gaps. And then after that, we have like pitching contests. And then in this pitching context, they get advice from experts within that field, who then guide them on this. And we award the best, but it's more of not just something just to have that, just to trigger that motivation into giving your best in this simulated project that you're working on, so that at least by the time they also now engage in the actual project, there's a bit of competence to it. Yeah. So
Okay.
basically, I would say 6 months. That was actually the one that we found to be quite, yeah, that had very good outcomes.
Right. So, as a part of my PhD, I was also looking at the pharmacy curriculum and how antimicrobial resistance and antimicrobial stewardship is dealt in our curriculum. So, I did my study in India, South Africa, and the UK. And I found that in all these three countries, in the basic pharmacy curriculum, AMR was not really a major focus. So, we do learn about pharmacology, we do learn about mechanisms of action, ADR, and things like that, but that was more like a theoretical just for clearing your exams. And we I didn't know about antimicrobial resistance until I started working in it.
Yeah.
So which is why even with FCPI we are trying to provide a lot of practical trainings to students rather than just theoretical just by hearting stuff, but just to show them how we transition from the theoretical part to actually applying those principles in the clinical practice. So
Yeah.
really great to know that you are also doing something on similar lines with the students in Kenya. So
Yeah. But okay, but maybe just to share on that, because you've touched on the curriculum, I
hmm,
think what we are doing is it's good work, but I would also say it's not very well integrated and quite, quite scalable. I think we've tried to initiate conversations into how do we then ingrain some of these, because even as we train, we can train at so many, we can't like cover all the pharmacy schools within the
of course,
country.
of course.
Yeah, so for us, we do pilots, but one of the one of our long-term goals that we have is based on that relationship that we build with, with the government,
Hmm.
especially the government departments that are working on AMR. We hope that someday we might be able to also integrate or revise, although, revising the curriculum is now a whole mountain
Yes,
by itself.
yes,
But we hope, it will actually reach a point whereby through these efforts that we are doing, we'll have that ripple effect whereby we have a bit of emphasis on AMR, in our curriculums. Because I also agree,
absolutely.
also myself when I was in school, we kind of touched everything, but there
Hmm.
wasn't that. It was more of technical, just telling you what is resistance, what happens
Hmm.
in resistance. But in terms of putting it context with our current reality as a world, that wasn't really addressed. So we hope that we reach to that point whereby um, we integrate this education with the
With the
practical aspect
curriculum.
of it, but also try to package it in a way that people realize it's not just a thing in the books that you need to know
Hmm.
about,
Hmm.
something that's actually happening. Yeah, and I
Yes.
think that would have really very tremendous impact. Yeah,
Yes. And I also like the fact that it's more like a train the trainer model or like a peer learning process where you train a batch of students and they go back and teach their peers. So I think that sort of ensures the sustainability of the program also to an extent because like you said, you can't reach out to all the pharmacy students in Kenya. That
yeah,
takes time. But I think this model would really work where you are training a small group, they go back and train a larger group. So I think that's a good intervention or initiative from your end that you've taken. So I was actually I'm currently more interested to work with students on AMR and antimicrobial
absolutely.
stewardship, especially with school students, so high school students. So that's something that
Yeah.
has that I've got interested into for the past few
Mm.
months. So I actually wanted to know from you, like, when you work with school students or early career professionals, what are some things, what are some considerations that you keep in mind? Because like you said, they are very young minds and they may not be affected by all the norms and systems in place, so they're very new and very fresh and easy to mold.
Yeah.
So how do you what are some of the considerations that you keep in mind when you interact or engage with them?
Yeah, we also do a bit of work on secondary schools. Maybe if you want, we can talk a bit about that.
Yes, yes.
Yeah, but before I go to that, it's a very good question, and maybe also let me look at it from the aspect of safeguarding. It's very important especially when you're engaging the young ones. Yes, they are they are not very much exposed. But that has its advantages in that you can train them a lot. But it
Hmm.
also has its disadvantages because people can actually kind of take advantage of the same model and all that. So for us, what we do is that first we have safeguarding measures. Even in our website, if you visit, there are a number of public access safeguarding policies that
Okay.
in one country that we adhere to, both for the youth and both for the children, that is people under the age of 18. So they are a bit
Mm-hmm.
different because also dynamics are a bit different here.
Mm-hmm.
But now focusing on the on the youth, we have something that I've been quite vocal about for a long time, in regards to meaningful youth engagement. I think that's very important. And for us, as we engage people, there's knowledge hierarchies. I think I have quite a lot of interest in researching it, and I might be doing a lot of work in the coming years along this line. We don't train people from the aspect of they don't know and we know,
Mm.
because that one of the things is that it has that effect of introducing a power dynamic.
Yes.
And power
Yes.
dynamics always exist, but I think it's also very good to be very intentional in terms of trying to reduce these power dynamics. So you tell them, okay, this is what we know and this is what we'll give you. But at the same time, you also know many things that we don't know about in regards to you are the ones who are in maybe a particular setting. So you know best about, even if it's with training,
Absolutely.
you know best how to contextualize this to the same. And at the same time, it's also one of the reasons we have this peer learning and we have actually people present on the same and, share their aspect on these, so that just to showcase that no one has the monotony of knowledge.
Mm-hmm.
And in as far as we know this, they also know something. The other aspect that, and this we've found to, it kind of creates a very good camaraderie and a very good symbiotic relationship, such that, you kind of become like a family in a way.
Mm-hmm.
The other aspect also that I shared before is on the aspect of giving people autonomy or allowing self-determination or a bit of self-determination in regards to what people do. Because one of the things that we've noted, some of the work that we've done within Africa, there's been a lot of sustainable initiatives. What I mean is that there are people that we are engaged in a program. We no longer, and one of the things that we do is that we don't kind of have a grasp. What I mean is we don't take that grasp whereby if we're engaging students in a certain project, then we overload them and, okay, when you finish, this will still be ours. And, some of the projects that actually happen is registration of entities. For example, clubs, others registering non-profit organization and all that. So we give them that autonomy, one in terms of them coming up with the idea in terms of what they want to do. So for us, what we do is we tell them, okay, this is the budget that we have. So you go out there within the setting that you want. If you're interested in a facility, go there. But we don't restrict them to facility because also it's also good to look at pharmacy from a very wide aspect. There are some people who through their, because like for me the work I do, I use a lot of things that I learned in pharmacy still to even though I don't work in clinical practice as such, but there's a lot of knowledge that I use of what I learned. So they are the ones who come up with the ideas. We just help them mold them and then give them the seed funding to do that. And for those that end up forming structures or coming up with initiatives, we give them that autonomy to run these structures in the way that they deem fit. We have like so many organizations that we formed, but we don't have a consortium. Like not to mean that consortiums are bad, but we don't have that overarching governing body to say that we are the
Right.
ones who
Right.
supported all this. Yeah.
Mm-hmm. Yeah.
So that's
So
one of the.
yeah. Yeah.
Mhm.
Sorry. Go ahead.
Go
Go
ahead.
ahead. Go ahead.
Yeah. So no, you can just share because the other one I just wanted to also share is the aspect of also high schools. Maybe just to share a bit on the same.
Yeah. No,
Yeah.
I
So
was.
for the
Sorry, sorry. No, I was just
no, go
saying,
ahead.
in one of the research projects that I worked in, they initially started off by saying capacity building, but they later changed that to capacity strengthening with the same notion that you were just discussing. So when you
Yeah.
say capacity building, it's almost like you are approaching the group thinking that they have zero expertise, they don't have any
Yeah.
experience, and you're going there to build capacity in them. Whereas when
Yeah.
you just turn that, that terminology to capacity strengthening, it means that
Yeah.
they have some existing experience and you're there just to support them. So they
Yeah.
have all the autonomy, they have all the decision making power. You're just there to support their activities. So I think that
Yeah.
change and shift, that shift in idea and shift in just the words that we use makes a lot of impact, I feel. Yeah, I just felt that
Yeah.
sort of resonated with me and thought, when made me go back to that time. Yeah. Sorry, go ahead with your, yeah. So you're
Yeah,
talking
yeah,
about your
it's
high.
okay. And maybe just to share on the same, now that you see, like we kind of have a new organization. It's our very old organization, and so we'll still be engaging in AMR, but also kind of it's a bit broad, also covers other areas, and that's also one of the areas that we want to do a lot of research on in terms of understanding all these dynamics and how they
Mm,
influence sustainability of projects. Because I've worked in I've implemented antimicrobial stewardship, from a pharmacy perspective, doing a bit of training, trying to interventions. But you find that it's very important because you see, where if you go to a facility and implementing something and they're saying, okay, there is this project that is usually that we do with this organization. You see, it's kind of not integrated. It's kind of a side
standalone.
alone. Yeah. And one that it's very, maybe it's very good, it's very lucrative, but the fact that it's a standalone project, then that means that even after, if that funding ends or dies away, then it will die away with the project. So it's not just among the tertiary students or right careers, but also even in our mainstream practice. I think we need to think of ways to, and there are so many barriers to it and all that, and but I think it's good to start thinking along these lines and to try where we can. For example, I feel if I went to a facility and told them, okay, let's have this conversation. I have these funds in place and we want to do something with you guys. Okay, usually they are the things that you obviously, when they prescribe you, okay, we are like, okay, so we want you just do a bit of a bit of research within your facility and note, we want to strengthen antimicrobial stewardship within this facility. So what are the gaps that you see that you have as a facility, and where would you want us to start? And on our end, we're also trying to integrate this. I think having it from this model might end, it might end up being very sustainable rather than where we come with, okay, we have this project
Yeah.
that we want to do. It's very structured and
Yeah.
it's very rigid that we have to implement it this way. And the thing is, having worked in quite a number of low resource settings, low income countries in Kenya, I think this is also the same for any country.
Mm.
You know, the moment you come up with that project, people will take in, people will be rude, they will welcome you, let's do this
Mm.
project, they will learn alone and all that. But the moment it ends, because it was never their project, there was no that
True.
component of
True.
ownership.
True.
So I think even as you are thinking around antimicrobial stewardship, it's very good we think of, issues to do with ownership of and how we actually ensure sustenance and not just like having it in not just having it in, okay guys, so we are doing this project and we want you to sustain it and all that. It's not
Mm.
just in terms of words and giving lectures, but also the project designs and all that. I think it's something that we need to start having serious conversations on,
Yes. Yes.
especially for us in this area. Yeah.
Yes.
So now, going to the high school work, I've done a lot of high school work,
Mm-hmm.
especially in Tanzania. And for there, we had quite a very systematic approach in this. So what we did, we worked with a team. And actually, this was a team of, so right now they are medical doctors. Back
Okay.
then, they were
Okay.
finishing their studies. But they are still going on with the project, even as
Okay.
they're working facilities and all that. So what we did is that we thought from a systemic viewpoint of, okay, we want to engage with high school students, but we had done a lot of outreaches, going to a school and all that. But we tried to look at it from a point of now the curriculum aspect in regards to so what we thought is that let's come up with a product that we can that is actually has a lot of human-centered design and a lot of participation into it. So we approached teachers, some AMR experts within the country, and also some students. And what we did, we came up with a handbook, a kind of a comical handbook, but it has so many components to it. It
Nice.
has a storytelling line. It's kind of anchored in One Health. And it's kind of not just sharing information, but also it's the story of a high school kid. We call him Misondo. And and it's in Swahili because Tanzania Swahili is it's a very highly spoken language. And
Right.
so Misondo, it's the story kind of, and then the storyline is very much entrenched into sorry, the Tanzanian kind of, what happens in the Tanzanian realities.
The
So that
context.
doesn't seem, yeah, doesn't seem as a very far-fetched.
Hmm.
So what we did, we designed this handbook, and also we took a lot of input. And after that, before that, we kind of did, before we did a bit of pre needs assessment in one secondary school. And
Mhm.
so we developed the book. And now we're in the process of now trying to now pilot it, try to assess its effectiveness. And
Okay.
surprisingly, the Prime Minister of Tanzania actually came across the book in one of the settings,
Oh,
and he was actually very pleased. So right now the team
nice.
is like in conversation with the Prime Minister office and various ministries, and we hope that
Amazing.
that will maybe help in terms of now
Yeah.
distribution of this book after it has actually been piloted to maybe the region first. But we hope
Mhm.
that because now changing the curriculum is a very
Yes.
heavy process. But we have this book then added and distributed, and students can read it. I think it will, yeah. So that's the work that's the, I would say, the exemplary project that we've done in
Amazing,
that.
amazing. Yeah, and I really like that you are sort of making it age appropriate. So for school
Yeah,
students, it's more like comics and stories and making them relatable to the character. So I think that's
yeah,
very important because they don't know about the global issue, and there's no
yeah,
point in talking to them about antimicrobial resistance from a very sophisticated manner. But the minute you put some comics and some storyline to it, they become intrigued and they become interested in that. So I really like that concept of how you sort of changed a very complex topic into a comic style storytelling for the students. So that's very interesting. And I also
yeah,
like the fact that you try and sort of contextualize everything. So it's not so some many a times what happens is that we blindly follow Western guidelines or things that have been developed and put together as guidelines by the global North. But our context is very different. So what you
yeah,
experience in Kenya or what you experience in Tanzania and what I experience in India is very different. But
yeah,
a lot of times we fail in sort of contextualizing those what we see online, what we see from guidelines. So I think it's like you mentioned, it's very important that you contextualize these ideas and you first identify what the problem is in your setting and have some good buy-in and good co-designing with the local
yeah,
stakeholders. Otherwise, like you mentioned, they just see it as a project. They may
yeah,
engage with you to a certain degree, but they never own it. So
yeah,
it's like you come, you do, and you leave with the project. Nobody cares. So
yeah.
yeah.
And I think on that is, that's the hard route. It's the route that, like it
Yes.
involves a lot of work to do all these things and a lot of resources too. And I think maybe even as we are doing this work, sometimes I think it's also good, sometimes no one, we might not be able to do it maybe based on the resources that someone has to go to that full stretch. But I think just being intentional in terms of, not just taking the shorter route, because the shorter route is to develop a project, come, do it, quick results,
Yes. Yes.
very good outcomes, do a very good paper, put it
Mm.
there,
Mm.
get another grant, do another work somewhere,
Yeah.
we'll all, find you as a very esteemed professional who has
Mm.
done so much impact. But when you go to that facility, 3 years down the line after leaving this facility,
Mm.
what you say, is it sustaining? So I think it's always good maybe to, we take a step back and ask
Yep.
ourselves, okay, why are we doing this in the long run? Why am I investing my time working in this field? It's
Mm.
because I want to see a change. If I want to see a change, then I have to be ready to maybe hit a bit of obstacles here and there. I have to be ready sometimes to take up down a step and realize, even though I've learned so much and I have so much knowledge, I
Mm.
might know everything. Sometimes I have to listen rather than
Yes.
speak, Yeah.
Yeah. Yeah. So, like I was talking to you in the beginning of the podcast, I recently did a webinar for African students, and I was really amazed at the level of knowledge and engagement that the students there have, especially around antimicrobial resistance. The kind of questions they were asking, their thought process was very interesting for me, and I was quite amused at them asking these questions at a very young age. So for me, I learned about all these after I became a professional. So while I was studying, I didn't know about these things, but I think a lot of the students are getting a lot of exposure from the different courses and different institutions, and they have like a baseline understanding. So the questions they ask are also very thought provoking for us
Yeah,
as preceptors or as educators. So I actually wanted to know from your perspective as an educator, what are some of the things that you have learned from the students that you have trained? Is there anything that has
yeah.
impacted you as a professional?
Yeah, I think first is that they have challenged me a lot. Seeing the things that some of them do, I'm like, it inspires me a lot. I'll say that one of the things it drives me and it actually like inspires me to do more.
Mm,
That's one of the key, I would say, the key lesson or key outcome out of these interactions. Because you interact with someone, they have very big ambitions
yes.
and they have like some calculated steps on actually on how they plan to reach there, and you're like, whoa,
Mm,
that's amazing.
mm,
But apart from this, I think one of the things that I have I also learned is the need to appreciate context, because for us to like
yes.
design things that are very context specific, it took a bit of time to to listen. So I think context really matters. And when we are framing things, I think it's also very important, even when we are giving knowledge, to always, before we used to do, like if we are doing a session and teaching on this, we focus more on, the theoretical aspect.
Mm,
But even when you are focusing on the theoretical aspect, I think one of the things we learned is to also place some reality into it, to maybe have a case study, that presentation that you are doing, or the teaching model that you're doing, have a case study, have them discuss it or kind of touch a bit on a scenario. If you are teaching on something, just tell them, okay, this is the dynamic that is happening. I think that is one of the, and it also arose from, the kind of questions that people are asking. Because you are there maybe teaching so much about the theoretical, but someone is here asking you a practical question. So you're like, maybe I got it wrong. This is not what people need. People
yeah.
need this other aspect. Um, and then the other thing that I think we learned so much is, when we began doing this in Africa, there was not so much going on. And I think the ripple effect has been good. Some of the students now, like people working whom were engaged in Nigeria, have gone ahead to even have their own programs on the same. So I think that ripple effect, the moment you see it, it also kind of is what made us to sit back and ask ourselves, okay, there's something that we did that brought in a bit of sustainability
Mm,
compared to what we were doing before.
yeah. It's quite
So,
rewarding to see that.
yeah, and it was, I would say it was not something that we expected, like we
Nice.
didn't have that vision that this would actually happen. So it
Nice.
made us sit back and ask, okay, why do people seem so passionate, like they are still doing this even if the project ended, the funding that we given them ended, but they are still like doing this. So it made us sit back, and that's when we started realizing the issue I'm talking about, the issue of autonomy, at least generating that ownership. And I think that's now what led to what we are now doing at Zihi, where we are trying now to see this model, because it worked with tertiary level students, can it also work for other target populations, especially in the areas, especially in the community, because we do a lot of community work, whereby we don't go to, even if a community is so much, maybe has a lot of issues to do with poverty and all that. But those people still, one way or another, even with all those difficulty, most of them see another day. They find
Mm,
ways to maneuver. They find ways to
mm,
adjust things to live and all that. And that's what drove us to now thinking of rather than go to a community and from a point of needs a need based aspect. We now use something we call asset based need response, whereby before we even engage a community, rather than starting with identifying gaps,
Hmm.
how we do this
Hmm.
assessment, we start with identifying assets or identifying the strengths in that community.
Nice.
Now
Nice.
asking ourselves, okay, these people have maybe these problems, but what are the assets or what are the strengths that
Hmm.
we have?
Hmm. Hmm.
And now after when now we identify the needs, now we see, so how can we match this to the strength that they have to actually address these gaps that they actually have, instead
Right.
of coming with an all package solution,
Hmm.
or just approaching, also how you communicate with people. For example, if you just show people that you are just immersed in problems and all that. Yeah, they have problems, but I think it kind of influences even the thought processes of people.
Hmm.
By if you show someone that, okay, yes, even within all this, there's something that you're also doing good. So when you tell them, okay, this one you can also do, there's a bit of confidence that comes with this, So I think this one of the things that it gave me like the next career investment that I'm actually making at the moment now. So I think that was shaped by the students. So I owe them that and this realization in terms of the work
Amazing.
that, yeah,
Amazing. And I think, like you rightly mentioned, communication plays a huge part. And
yeah,
many a times, what we do is we use the same way of communicating to all the different populations, all the different groups. We just try to communicate the facts, and we feel that okay, we are using a uniform messaging. But I think many a times that may not work. So this is
yeah,
what, even when I was doing my PhD, one of my interview participants, who was a pharmacist, he also mentioned like even when you're giving stewardship recommendations to clinicians, you make sure that you customize or you tailor it for the recipient. So when the
yeah,
way you give your recommendations to a surgeon is very different, should be very different from how you communicate to a physician. So that level of contextualization, that level of tailoring it to the recipient, I think that plays a huge role whenever we are developing interventions against AMR, the messaging for AMR. I think, like you rightly mentioned, the way we talk about it gives them ideas and makes them interested and engaging with us, and that actually helps in sustaining these works as well, which is very important when we talk about AMR.
yeah. That's amazing. I read your work a lot. The team is Mita, Candace,
Yeah.
Oluchi. Yeah, so I read you, and I think I really love the way that you approach, like the research that you do, because
Hmm.
it's addressing those, let me not call them minor, but those issues that we might, ignore even in
Yes.
the black, this to do with power dynamics, what all those things. I think sometimes we might ignore them, but the fact is that these are the drivers, that actually drive a lot of the way we, conduct our practice here. So it's really amazing work that you do, and it
Thank you
also
so
inspires
much.
me when
Thank
I
you so
get
much.
one or two that I can also implement from the same. Yeah.
Thank you so much. So I think my last question for you is there anything that you would, from your experience, obviously, is there anything that you would like to convey to our participants and also to people like me who are now more interested in doing community level work? So anything that you have learned. So you talked a lot about what you have learned and what you're doing, but anything that you have not touched upon that you would like to share with our participants?
Not really, but maybe in general, I would say that our field is very broad.
Hmm.
You don't have to, like, you shouldn't place your career in a box. I think you should always see it as something that is transiting.
Hmm.
The clinical practice is very good, but also as, we can always think of ways that, for example, the research that you do, there are so many components of it that are actually on, behavioral
Yes.
components,
Yes.
that I'm sure you never learned in a pharmacy class.
Yes.
So I think the best way is to see how we can integrate the technical skills that we have as
Hmm.
pharmacists and address many other areas. So I would encourage each one of us to, especially maybe those ones who are maybe going into the community engagement and all that, always think there's always a way that you can, build up on what you have, and you'll actually surely need it, and then add something and, yeah, do
Yeah.
much more impact.
Yeah.
And
Yeah, so just as a takeaway from my end, I think I would really like to encourage our participants to always think outside the box. And like Daniel, you rightly mentioned, there are a lot of opportunities for us, especially countries like India, Kenya, where clinical pharmacy is still quite evolving. It's not
Yeah.
a very established profession, and we are still getting to know the different aspects. So I think this discussions like these are very important, and the students also should be more open to these arenas, and not just go by the traditional roles that they have been taught on. So yeah, thank you so much, Daniel, for your very interesting discussions, and we wish you all the very best for all your future endeavors, and hope we'll meet someday in person as well.
Yeah, thank you. Thanks so much for the platform, Brinda, for inviting me. It's really happy to share about what I do and also to have access to your wonderful community. And I do appreciate, and yeah, we'll meet soon. That I'm sure. I also used to tell us meet at that, and
Yeah.
we met. So, yeah,
Yes.
thanks
Yeah,
so
thank you
much. I
so
do.
much.